this computer. Okay, so we'll talk about cancer then. And this topic is pretty relevant. There's not too many things. It kind of boils down to talking to your patient about educating them if they know they're about to go into cancer treatment. So kind of knowing what you want to share with them before they've gone into cancer treatment. And then it also talks about patients that you have in your chair that are in cancer treatment. And then, of course, the third one would be thinking about things that they may be dealing with after cancer treatment. And the chances of you seeing patients with cancer, it's just guaranteed. I mean, you're going to see them, of course, varying. Some cancers may be less severe and they may have less treatment and less side effects, and then some may be quite severe. So that, of course, will vary, but you will definitely see patients, and not just that, but patients, coworkers' family, your own family, patient's family. And so it's just very common. And so it's good to know these basic things. So here are the objectives for this unit. And then this is the outline. We'll talk about a little bit about terminology and risk factors and signs and symptoms very briefly. The oral cancer a little bit there, although you probably got, how much does Professor Sarmiento, does she talk? Does it kind of go along with your EOIO? Does she bring in any treatment, or is it just looking for? It's just looking. It's not okay. I probably could expand this, I suppose. There's always more information that can be added, which sometimes we just have to cut it off somewhere. And then we'll talk a little bit about the different kinds of cancer therapies, the management of the complications, and then sort of highlighting the process of cares, which is what you'll really want to sort of zone into. And then I have the university guidelines, which hopefully are the same. I don't think they've changed since last year. They are from last year's manual, but I can look at them after class, and if it's updated, I can paste it in, I can update it. Okay, so like I said, you'll see lots of patients with cancer or their families or someone. So it's good to have this basic information, know what the biggest oral manifestations are to be aware of, what you could recommend to your patient for comfort, or if they have a family, a husband and wife, anybody, you can, and they're in your chair talking to you about it, then you have some information to share. So it's very prevalent and common. So cancer terminology. So cancer is not a single disease. It affects, obviously, you can have all different types of cancers affecting different parts of the body. So it's not just one disease, but classification of over 100 different types of diseases and where they affect different parts of the body. Terminology, the definition for cancer: abnormal and unrestricted growth of cells that can invade and destroy surrounding normal tissue. So it's unregulated cell growth that starts to affect and invade normal, healthy tissue, sometimes spreading to other parts of the body, and that's metastasis. And then if it's a benign tumor, it's usually sort of well circumscribed, and oftentimes it's the similar or same cellular makeup of the kind of the parent tissue. So that's obviously not as serious, and oftentimes it might just require like surgery or just removal of the benign tumor. If it's malignant or a malignant neoplasm, and that word neoplasm, you kind of want to recognize that term and associate it with cancer. So you may see that word in reference to like treatment or neoplasm. Just recognize that word and have it trigger cancer in your mind, because you may see that word on the national board, or you may see it on the final, as opposed, in talking about medications too. So neoplasm, neoplastic, think cancer. It infiltrates. So if it's malignant, it infiltrates locally, but potential to metastasize. So it can move, it can get into the blood, and it can go to various parts of the body. Distant site cells are atypical and dysplastic and may not resemble the parent tissue at all, which of course is some of the major issues there. And then metastasize, like we've said, it spreads, goes to different places of the body. Oncology is the study and the treatment of cancer. And then an oncologist would be the cancer specialist, or the person specific, the physician would refer them to an oncologist who would take over the treatment and the care of that patient with their cancer. So risk factors, everyone can think of like those kind of typical risk factors, like, smoking and alcohol and, different things like that, that sort of kind of rise to the top. But there's other things too. Sunlight is an interesting one, because I know that everyone typically thinks about sunlight as causing skin cancer, but that's sort of an ongoing debate. There's a lot of literature that doesn't feel like that's been answered specifically. I mean, definitely there's reason to be cautious. Don't go out there and like bake yourself, but it sort of feels like a closed shut case, but there's actually some good literature about it that feels like maybe there's more to it than just the sun. There's other factors, but we've boiled it down to the sun exposure. But also hormones, things like estrogen, hormone treatments and things like that. Asbestos exposure to different chemicals or different products that they've used in the past. Radon is kind of natural. It's in like rock and in the earth. And so some areas have a higher amount of radon, and some houses, like a brick house, will have more radon than a wooden house. So there's radon in different materials. And then behavioral risk factors. So tobacco and alcohol, overweight or obesity, poor nutrition in general, inactivity, these things increase your risk for cancers. And then there's viral, hepatitis B, hepatitis C, I don't know why that's not on there, HIV and HPV. And then genetics, there's, they say, you guys have all heard this, that genetics loads the gun, but your environment and your habits pull the trigger. So just because you're genetically predisposed doesn't sentence you to cancer for sure, but there definitely are a lot of things in our environment that increase our risk. Even with a very healthy lifestyle, there's still a lot of environmental exposures. What does this say? In the US, only heart disease causes more deaths in adults than cancer. And that was a pre-COVID statement, but it's likely still true, but I should check that. Early signs and symptoms of cancer. So these are just some changes in your body that if you notice them, and they're going on, or someone in your family and they're not changing, then these are early signs. And sometimes they're not even super early, because a lot of times really early signs of cancer aren't actually even really noticeable. And that's some of the major problem with certain types of cancers, is nothing really seems to be wrong until it's quite an issue. So this says early signs, but sometimes that's not so early. It's not as early as we would like it to be. But change in bowel or bladder habits, non-healing sores, and we are familiar with that with the mouth, but that can be anywhere too, like a mole or something that bleeds and crusts over and bleeds and crusts over, it just doesn't heal. Unusual bleeding or discharge, thickening or lumps anywhere, any kind of a thickening or a lump. Indigestion, difficulty swallowing, that can signal perhaps there's like something growing in the throat, like a tumor growing in the throat. Obvious changes in a wart or a mole, a nagging cough or hoarseness. And these overlap with other conditions too, but any of those things should sort of definitely trigger a doctor's visit. So the rise in oropharyngeal cancers, we've seen that with the rise of HPV, and that's gone on now for several years. It's not super new. It used to be that it was just older men over 65 who smoked and drank. And, that's who we figured got oral cancer or throat cancer. But that's definitely changed with the rise of HPV. So now we have a whole different sort of subset of cancers and a different age population. And so adults under 45 can easily be at risk for oral or throat cancer, oropharyngeal. So that's why it's so important we do our little screenings. So the human papilloma virus is HPV, and it's specifically, they can like biopsy it and tell it that that's what is, if someone has throat cancer or oropharyngeal cancer, they can biopsy it and say, tell that that's what it is, that's what caused the cancer. So the location, which would be the most common, or the risk would be in the throat, back third of the tongue, the soft palate, sides, back walls of the throat, and then the tonsil area. So just in the, and it's all those kind of areas too, floor of the mouth, under the tongue, back of the tongue, back of the throat. Those are all your higher risk areas. So early signs and symptoms of oral cancer. So again, there's lots of things you'll notice. People won't notice something in their mouth and you'll see it and what healthy looks like. So unhealthy should jump out to you. When I was doing my, when I was working at the clinic over the summer, there was a guy, his dad taught, it was really interesting. His dad taught at his dad was a dentist and he taught at a dental school like Tufts or something. And this guy his dad was older, like probably in his 70s or 80s, because this guy was in his late 50s, I think. But he had a little spot, and at first, and this is a free clinic, he's just come in, and he had a little spot, and the dentists weren't checking. We were just doing cleanings and letting our patients go. But he had a little spot in his mouth, and I looked at it, and I asked him about it, and he wasn't sure. And then I was like, oh, no, I think he said something to me to kind of like let me know, like, oh, I saw that, or because at first I was going to just sort of like let him go, but you should get, and if you don't get it, train yourself to get it, like a nag in just like, I just want a second set of eyeballs to look at this. Even if it ends up being a cheek bite or it ends up being pizza palate, those things kind of stand out, but you should get an internal nag, like, I just want someone else to look at this, preferably the doctor, because but I've looked at stuff in the mouth and gone, I don't like the way that looks. And then I've gotten the doctor over and they've poo-pooed it. So and that's not to say that I was right and they were wrong, but it's just sometimes differing of opinions, or you just, the doctor maybe has looked at stuff long enough that he or she feels like they can be a judge with their eyeballs. So it's, it just depends. But anyway, so this guy, I said, oh, just wait a second. And then tracking down a dentist, that this thing was a feat unto itself, because the dentists were doing their own thing and running around seeing patients. And so I finally got someone over, and he did actually end up writing a referral for a biopsy. So I was like, oh my gosh, like, thank goodness. It's so easy to just tell them, well, look at it and make sure it goes away in 2 weeks. And then you sort of feel like you've done your due diligence. Like, you've told them, but they might not even know what you're talking about. They might kind of go, but nothing hurts. And so they're not likely to like inspect it and be thinking about it, so unless you take that second step. So it's just always better to err on the side of caution. Professor Ehrenfeld, I don't know if you guys if she's told you this story, but maybe in Q&A or something, or if anything with oral cancer screenings come up, maybe she'll talk to you guys about this. But she was sort of a dental expert for an oral cancer lawsuit, is the best way I can think of it. Has she talked to you guys about that? Well, maybe one day ask her if you guys have some time in Q&A, because the hygienist had made, and the doctor had made sort of not good enough notes, and had sort of the way the whole thing laid out, the patient felt they had a case that they didn't do enough to tell them that this was serious and you need to do something. So she was recruited to be like the dental expert to like review the notes and stuff. So I'm not sure how it all turned out, but that happens. That does happen. So anyways, maybe not off topic, but getting off of the slide. So early signs and symptoms. So these are things you just want to check for. You don't have to do the 10-minute or whatever your screening that you do in clinic. You will get faster and quicker. but you definitely want to make sure that your eyeballs has peeked. You peek through all the little hidden crevices in somebody's mouth. You know, I mean, I can say I definitely didn't thoroughly check people's scalps. You know, you do get to a point where you minimize it, but you need it to be effective, especially the areas intraorally that patients are not going to necessarily be looking at. That's, I feel like, our top responsibility. A lot of patients go to dermatologists and they should be looking. And if you notice something, certainly say something if you see it. But your oral cancer screening will tighten up and you'll get faster, but never let it drop. Yes. No, that's good. Yeah. It's one of the, yeah, you're supposed to palpate the tongue, feeling for like lumps and bumps. And it is a good thing to do. That is one of the intraoral ones that a lot of people drop. But one thing you can do is if you just get in the habit of grabbing gauze, have them stick out their tongue, whip it from side to side, and you have their tongue in your fingers, just do a little. It'll feel, it literally, it will feel thick. Like, you know, like your tongue will have like this soft, squishy feeling, and then all of a sudden you'll feel a harder area that just doesn't squish the same. It just literally feels, they say a thickening or a lump, but it's literally like, think of like a soft muscle as opposed to like when you tighten your muscle. Like it's the same thing. It'll, tongue feels all squishy, and then all of a sudden it's like, you know, and then sometimes, and if you do feel that, you feel for like edges, how big is it? You know, is it like a round thing or is it sort of like this diffuse? Some people have scarring. Some people have like chomped the heck out of their tongue in an accident and when they were young and it was like practically part of their tongue came off and they'll have like a scar or like a thickening and they might be able to, oh yeah, I did that. You know, they'll tell you about it. But if they don't think anything's wrong, then there could be something happening. But yeah, it'll have a definite feel. It's like lymph nodes or the thyroid. You're like, what does an abnormal thyroid even feel like? Because all you feel is healthy thyroids. And so you're like, oh, I guess. And then it's the same, you know, lymph node, usually you can feel it if it's, you know, big and, you know, that's little bit more obvious, but sometimes until you have felt something abnormal, you just know healthy, 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 healthy. But that's what makes abnormal stick out because you're like, normally this doesn't do this, you know, like a really spongy or like a little bump or something that just looks swollen, you know, that will be like, oh, not everyone feels that way. And so it's easy to feel like, I don't know what it would feel like, but you actually really would because all you feel generally is healthy stuff. um Ventral surface of the tongue, floor of the mouth, oropharynx. So this is, so and when you're seeing your patients, you know, these are similar from the last slide, but you remember the typical, if something is not healing and going away in the mouth, that's a problem because our mouth cells turn over incredibly fast. The mouth heals incredibly fast. So if something is not healing up and going away, that's not normal. That's not normal. Okay, so just, I feel like I probably spent enough time on this anyways, but what are some of the obvious reasons that you can think of why you may neglect an oral cancer screening? Running behind for sure. Time will absolutely do it. Also, anything at love, before I start giving all the answers, anything else? Well, yes, Brian. If the patient doesn't want it, that could happen if you, usually they're very grateful, thankfully, but that certainly could happen if they're kind of like, you know, what are you doing? Or I'm fine, or, you know, so you never know. Patients can say all kinds of funny things. Did I see a hand over there? Or no, no.
It's scarier if you're not able to speak or when you say, hey, I'm gonna palpate your collarbone.
Yeah, you're just touching them. They're like, and to both of your points, a patient that has never had a cancer screening, and then they get in your chair and you're doing all this stuff, that may be, they may be like, what are you doing? I've never had this done before. Chances are they'll still be grateful, but they might think it's weird at first. Did someone else back here? Yeah.
Yeah, I was concerned, are you using this just like as a dental hygienist or?
Yeah.
Okay, so
Like in your clinical practice.
like say for instance, like in my dentist, my hygienist doesn't do it, the dentist does.
Yes,
So
that's
whenever I'm
possible.
doing these, like, phone time, I'm using-
So that's a really good point. So when I worked for Dr. Matsuda, he did our patients, well, we did have a base of recall patients that we saw, but a lot of patients came in for surgery, SRP, maybe a year of periodontal therapy, and then they left. So Dr. Matsuda did an incredibly thorough cancer screening. And so I never felt like I had to do a super thorough one, but I still caught, I mean, like a patient had cancer on their lip, and I still said, hey, what's this? And then he's like, oh, okay. And then, so you still, but I never did like a thorough cancer screening because Dr. Matsuda did it, but I still looked. So you'll still look, but that's a great point because if then you go from an office where the dentist does it to an office where the dentist doesn't do it and they expect you to do it on a yearly basis, and that communication hasn't happened, then that patient could fall through the cracks. So it's just really important to know the office, the protocols, and bring that up, to the office so that they know who's doing what. Yeah.
Also, like, because we're doing oral pathology when it comes to our capstone.
Oh, good.
And after speaking with Lisa Rowley last week too, she was telling us that when it comes to like CP courses, that they're not required for a lot of states to like us to on like oral pathology.
Oh,
So the comparability of hygienists actually diagnosing those kinds of things.
Uh-huh.
We get like, the regular basic education.
Yeah.
That's it.
and then a lot of that stuff falls away, and yeah.
People sit and it's like 1 month diagnosis.
Yeah. And I don't know. Yeah, we probably don't diagnose because really even a dentist can't diagnose an oral pathology in the mouth. Like you can't really do it until you have a biopsy, but recognizing and then knowing what steps to take is super important. And I think that falls away a lot of times. Like, you see stuff and you're like, well, maybe that's just, linea alba, or, you just kind of chalk it up in your mind. And so, yeah, that's a good point though. So now moving from that topic, cancer therapies. So this is just in general, like overall cancers. So the goal is to kill the cancer cells, obviously. But the problem is that the treatment is pretty rough. And so obviously the treatment is trying to kill a cancer, but usually almost always, I don't know if there's an exception, probably always healthy cells get killed at the same time. So the point is to kill the cancer before you hurt the patient too much. And if it's a earlier stage cancer or easier treated cancer, then that's much likelier. But if it's stage 4 or it's a very difficult cancer to treat, then of course that changes the ratio. Different types of treatment here. There's chemotherapy, that's just with medicines, chemicals, IVs, pills. That's just, your traditional, what you might think of as medication. Then there's bone marrow transplant, radiation, and then there's surgeries. And then there's these other sort of subcategories. There's blood transplant, hormone therapies. My aunt she did all sorts of incredibly interesting alternative therapies. She did immunotherapy and hormonal therapies. Then there's also target therapies and stem cell transplants. And we don't go into a lot of those in details, but there's a lot of different thoughts when it comes to like, especially alternative treatments. So biopsies, surgical removal of either part of the lesion just to kind of see what's going on, maybe figure out the borders of a tumor or a cancer grouping. So treatment not only, it also targets healthy cells, like I said. So chemotherapy, the most common complication when we're talking about chemotherapy is going to be secondary infections due to their fact that their immune system is just compromised. We sort of get used to this idea of patients with a weakened immune system and they're susceptible to XYZ. We kind of see this in multiple populations, depending on like what kind of, if they're taking something, and if they're taking an immunosuppressant because of organ transplant or because of some other reason, there's lots of different reasons that they may take something that suppresses their immune system, autoimmune conditions. And so we just know that if someone's immune system is compromised or weakened, they're more susceptible to candidiasis, other bacterial infections, mucositis, all kinds of different things. The result of myelosuppression or suppression of the bone marrow, which your bone marrow produces all kinds of blood cells and has a lot to do with your immune system. So if you've suppressed that you're suppressing the immune system. Other complications could be like electrolyte imbalance, bleeding, the kind of thrombocytopenia or bleeding, hemorrhaging, acute toxicity. So when they get the big dosage of that medication, they'll acutely get a toxic effect, perhaps depending on the dosage of the medicine, what kind of medicine, and their reaction. Some people handle stuff better than others, but nausea, vomiting, photosensitivity, being sensitive to light, going outside, central nervous system dysfunction, alopecia, hair loss, and then just poor nutritional status, losing their appetite, not being able to get nutrients in their bodies that they need. It's going to increase the likelihood of all this sepsis, like in blood infection, periodontal disease, pulpal disease, and pericorneal disease. So they could have a bone marrow transplant. This is another type of treatment that they could be undergoing. And this could be used in aplastic anemia, leukemia, lymphomas, neuroblastomas, immunodeficiency diseases, or some solid tumors. So there's a number of reasons they might have a bone marrow transplant. And this process, they go through a conditioning process, which basically makes them super sick and vulnerable. So they basically wipe out their immune system in order to prepare the body to take on this new bone marrow. So it's like wipe out what you got with the cancer in it, just wipe it out and then put in fresh, healthy, in the hopes that your body takes that on and goes, oh, good, I can work with this. So it involves high dose chemo, radiation, destroys malignant cells, suppresses the immune system, permanent, this is not the right word, permanent engraftment of healthy bone marrow or blood stem cells via IV. So they give you it through an IV. And then the patient's body begins to produce their own new bone marrow within a couple weeks. So it's very precarious time. Has anyone had family or friends or anyone known anyone with a bone marrow transplant? Yeah, you have. Yeah, I'm sure it's pretty hefty to be going through that or knowing someone who goes through it. Bone marrow transplant. So there's something called graft versus host disease. And so this is basically when the body's not liking it, not accepting it easily. And there's two different kinds. It could happen acutely. So again, we always think of acute as happening now, fast, right, right away. So within the first 100 days, some of their symptoms or side effects or manifestations could be some skin, enteritis, dermatitis, hepatitis, so inflammation of these different areas. But then for us, we could see xerostomia, mucositis, ulcerations, bleeding, easier bleeding, lupus-like lesions, atrophy of the mucosa, thinning of the mucosa, and then opportunistic infections. Alternately, they could have a chronic reaction or graft versus host disease. And this would look a little bit more like an autoimmune disease. So it would come on a little bit later. And again, they could have things that affect the oral cavity. So oral mucositis that doesn't seem to be clearing up, salivary gland dysfunction. Those would be big ones that would be affecting the oral cavity. And then if what they basically do would they would suppress the patient's immune system to try and get them to not react so significantly to the new bone marrow. So patients who are scheduled for bone marrow transplant should undergo a thorough oral and dental evaluation treatment prior to the transplant. Their mouth should be as healthy as it could possibly be. And this pretty much is the same for anybody really going through cancer treatment, but especially something as significant as this. All potential sources of infection and irritation should be treated because chronic asymptomatic oral infections can become acute during immunosuppression. and it can lead to sepsis or even death. So something that doesn't seem like it would be a big deal can become a huge deal for someone who is this susceptible and kind of at a weakened state. So some oral considerations for chemo and bone marrow transplant: oral mucositis, neurotoxicity, infection, bleeding, salivary gland dysfunction, dental caries, increased risk to dental caries, and altered tooth development if it's a child. So you can read a little bit more on the details, but those are all things that we could expect to possibly see more of. Preventing and managing oral complication helps to support them through cancer treatment. So if you have a patient that's about to go through cancer treatment, if you let them know some of this stuff ahead of time, kind of mentally prepare them, you would expect their oncologist and their oncology team to do this. But if you have them in your chair, take that opportunity to ask them about what they've heard about some of the oral side effects. And if they say none, then say, well, these are some things that may occur depending on how you react to treatment. And so it's just nice to know this stuff. And it kind of gives them another, they are given so much information. When someone is diagnosed with cancer, it is like overwhelming amount of information and schedules. So if you are someone that they can sort of rely on, if like they all of a sudden realize like, oh, my mouth is sore after that treatment, I didn't think about it prior, let me call my dentist or hygienist and ask them about, what did you say I should do again? Because my mouth actually really does hurt. So, just to know that they have a confidant or to someone to help them. So mucositis is a big one. That's going to be one of the main manifestations that someone with chemotherapy or cancer treatment. And so it's because chemotherapy is toxic to healthy cells. And so you're going to end up seeing some kind of swelling, inflammation, ulcerations. Patients report burning, general discomfort. It makes eating very uncomfortable. Talking, swallowing can be incredibly painful. I've gone to CE courses where cancer survivors have talked about their like peak of discomfort and how like water hurt to drink. Like it hurt to drink water. And you just wouldn't think that. You'd think water would be soothing, like suck on some ice chips. That should feel good, right? But sometimes the inflammation is so severe that everything hurts. So keep oral environment moist and clean. If it's like that thing, where they say, take your pain meds, stay on top of your pain. It's the same thing, stay on top of a healthier, moisturized oral environment. It's almost like if it gets to the bad point, you just can't get back because they're too unhealthy to get back to the good point. So keep it healthy, keep it moist, and hopefully you minimize the mucositis. So good overall nutrition, control secondary infections. Patients rinse with saline or sodium bicarbonate, alcohol-free rinses, and they can use some analgesics and different things. I have a bunch of stuff here in the notes. Read through this stuff. This is good information, just to added information, just for to kind of expand your understanding of this. But I won't read through that just for time's sake. But management of mouth pain for mucositis. So this is some good information to just be aware of. This is the kind of stuff that you want to pick out what sticks in your brain, or develop a pamphlet if your work doesn't have one, or find one that's already been made and have a handout for patients that are going to go through cancer treatment. So you can be like, oh, this is some things that you can start before treatment or have ready for once treatment starts. Early detection of oral infections and prevention is the key. Good oral hygiene, brushing the tongue, keeping all the surfaces clean, frequent irrigation with baking soda or a saline rinse, frequent rinses. Well, that's like a spry or biotin, something that moisturizes as well. So they can do a baking soda rinse, they can do and then like a xylitol or biotin rinse. And then if they're in pain, they can use the topicals. We've already kind of had that in the other slide. Over the counter. And then avoiding acidic foods, spicy foods, rough foods, corn chips, anything that's like crunchy bread, things that would be rough on the mucosa. So eating more like neutral, blander, softer things, not necessarily sugary or fermented carbohydrates, but just, you know, maybe things that are like lots of probably soups and blended things. Use of perioral moisturizers and as directed by the oncologist. So they usually recommend some things. They may even have some standing orders for certain things, but so that's why it's also good to connect with the oncologist and find out what their routine is. So let's take a little break here. Let's take my clock says 10:02, so let's come back at 10:10. What did I just do to my phone? I want to sorry, I'm trying to delete now. It's in settings. Oh, it's good. Yeah. There we go. Now it's on. It shouldn't do that again. Oh, what? Whoa. It's like really just. That's it. It's just, I didn't even touch anything. No, ever. Okay, so that was on. So now it's your orientation lock off. So if you want it on. That's so weird. There. And then, oh wait. Okay, now it's all locked. You should do that. Oh, I wonder if you just did it. Oh no, it's like how bizarro. Okay. I haven't turned mine in, so I'm just gonna. Yeah. Thank you. Did you get that in the? I'll put a check on it and then I'll just double check my thing to make sure that I thought that everyone, I'll write myself a note that you handed yours in. I probably just forgot to check. So that's usually my thing, so I can tell who did what. Select. Back to the topic. So some terms, so we kind of, so mucositis, so, I was thinking about it, and the nice thing about mucositis, if there's a nice thing, is that, or not just that, but the thing about some of these conditions that are caused by multiple conditions is that you only have to, like, mucositis can be in a patient that's on hospice. It can be, like an elderly person that is in hospice care. Mucositis can be with someone who has cancer. Mucositis can be in somebody who's taking some medication for some other unrelated to cancer, some other condition. So you can lump mucositis and it branches off to multiple different things, but the treatment and the recommendations are the same. So if you look in somebody's mouth and you know that they're undergoing some kind of heavy treatment for something, or they're taking a pretty gnarly medication, and you can see signs of mucositis, and they're telling, my whole mouth burns and it just feels really sensitive, and you're like, oh, it looks like you have oral mucositis, you know that there's just kind of one pretty simple recommendation from that point on. So that's what's, there's a lot of these things, like when we're talking about patient care alterations in this class, a lot of the same recommendation goes out to multiple different, patients with different, so adjusting home care or adjusting the grip of a toothbrush, making it a larger handle, that's going to apply to, people in different categories, people with neuromuscular issues, an elderly individual, or somebody with some other special needs. So there's a lot of these things overlap. So I was just thinking about how that's actually kind of a nice thing for having to remember this material. So neurotoxicity, that's the next major sort of oral manifestation, and that's damage to the nerve tissue caused by the toxic substances in the chemotherapeutics. So a lot of them are derived from plant alkaloids, which are toxic to us. So specifically to the nerve tissue, can cause severe, deep pain. Often it's going to be bilateral, and it's going to feel like odontogenic pain. So it's going to feel like tooth pain to them, perhaps. Pain subsides a few days after the drug is administered. So if they go in for chemotherapy, like say every other week or every 9 days or 14 days or something like that, they may get sort of an uptick of this pain, this neurotoxic related pain, and then it might subside again. And there's a little bit more detail on the side, but it pretty much says the same thing there. And then the next one, let me get my infections. So when the bone marrow is suppressed, we kind of already breezed over this, but when the bone marrow is suppressed, they're in an immunosuppressed state, and they can have immunosuppression and bleeding problems. So the risk of developing oral infections, a bacterial or a viral infection, if, a lot of us carry the herpes, like a lot of us have it, like 98% of people have the herpes virus, but not everybody expresses it. So somebody may actually express that virus if they're in an immunocompromised state. And then of course, fungal infections, candidiasis, increased risk of systemic infection could lead to death, and of course, intensify mucositis. So management, the oncologist should decide the safest time to schedule dental hygiene appointments. They may recommend a pre-med, especially if they have a catheter or a port for the medications. And then stop brushing and flossing. That may be something that you hear from an oncologist, or you may see that in the literature. And that's purely sort of dependent on like their stage, and what they're afraid of is a bacteremia. But if you stop it, what's going to happen? Do we stop producing like plaque and bacteria? So it's kind of a controversial thing, but there may be alternate ways of recommending things like the sponges, the chlorhexidine sponges, or an extra soft brush, so you're not being rough on the mucosa at all. So there's options there, but would be a good point of communication. Denture wearers evaluate frequently to make sure something's not rubbing, that their tissue is okay underneath the denture. Taking the denture out at night, soaking it and disinfecting it to make sure, because they'll re-inoculate themselves. Like if they take it out and cleanse it, but their mouth still has an overgrowth of candida, they'll re-inoculate the denture. And then even if they get their mouth cleared up, if it's on the denture, they'll, you know what I'm saying? It can be a vicious cycle. So they need to clear it up in their mouth, but they also need to clear it up on the denture. So usually they have to go a little ways, a little time of not wearing the denture, fully disinfecting the denture, and then clearing up the candida in their oral cavity before they can get back to their regular routine. Hemorrhaging, so bleeding disorders, the thrombocytopenia, or that reduction in the clotting factor, can be or a low platelet level, that can be a side effect of the cancer medication. So there's some numbers you don't have to memorize these numbers, but these are just some numbers based on their if they have testing on their platelet levels. Increased bleeding during debridement, if they are less than 50,000, whatever, however you say this, I'm not sure exactly how they would say that out loud. And then less than 20,000, so if they're really low platelet levels, they can just have spontaneous bleeding in their mouth. So management for this, consult the oncologist again as to the patient's blood count, and if it's a concern, if they should even have their dental care. And then trauma from improper brushing or an ill-fitting denture could initiate the bleeding. So we usually would give them an extra soft toothbrush. They make these toothbrushes for, Dr. Matsuda had them to give to his patients who had like a graft, and you want to just very gently debride it. There's like the bristles just feel like a feather. I mean, they're just very, very soft. Trauma for, I said that already. If dental procedure is imperative, they absolutely have to have it, then platelet support therapy may be given by the oncologist. So this would be a case where something arised either during their treatment that maybe wasn't noted before, or they didn't have somebody let their dental issues through the gate and then they started treatment and something made it worse. So this is like why it's so important for them to have everything done before they start any kind of cancer treatment. But maybe something happened, maybe something in the cancer treatment made something happen in their mouth, and that's why they have to actually have some work done while they're in cancer treatment, which would not be ideal. Salivary gland dysfunction and dental caries, dry mouth, thickened secretion, ropey, thick saliva that's not really benefiting. It's just kind of thick and there, but it's not moisturizing and rinsing like what we want our saliva to do. Excessive drooling may occur during chemotherapy as well. Dental caries not specifically linked to the chemotherapy, but rather just the chronic dry mouth, the increased intake of maybe, less than ideal food because of what they maybe feel like they can and can't eat. And so maybe higher amounts of carbohydrates, and then just poor oral hygiene. They're very tired. They may be throwing up. They may have no appetite. Like all of these things together is going to make them not want to be like the most fastidious, perfect oral hygiene to begin with. So they have a challenge. They're up against a challenge just with how they feel overall. So management, nutritional counseling, fluoride trays are oftentimes prescribed prior to cancer treatment. Just sort of, the oncologist may say, go to your dentist and get fluoride trays. That might just be their standard of care. Staying hydrated, counseling the primary caregivers and the family, and oral hygiene techniques review and altering them depending on the patient's needs. So a little bit for radiation for head and neck cancer. If somebody's undergoing radiation therapy, they're undergoing an ionizing radiation treatment. And so that obviously is damaging biological cells. And we know ionizing radiation damages healthy cells as well as cancer cells. And they may either have it from an external source, or it could be an internal, like a little pill or something that they put in, or an implant that they put in that radiates. And then examples of cancers that may need radiation could be, of course, we know head neck cancers, oropharyngeal lymphomas, salivary gland tumors. And then we would see the results of that in an oral manifestation. So a lesion of less than 1 centimeter may require just surgery or radiation if it's small and superficial. Damage to normal cells may be acute and they could just resolve after therapy. So a lot of times we can see if it's not tremendous amount of radiation, they may have some temporary damage, but things may come back and resolve. Other normal cells may not be able to repair themselves. Long-term complications could be with the salivary gland. So that doesn't mean for sure 100%, but it could also be one of those things where they have some damage. They still feel like their mouth is moisturized, but their saliva levels are lower than they used to be. So they may see an uptick of caries after treatment, even though they feel like they have saliva and things like that, but it may have diminished it. So they are hyposalivating. They're not salivating to the same extent. So they may still always want to be aware of using xylitol products, fluoride, topical fluoride, whatever, to help counter that. So if they are having acute oral manifestations from this therapy, they're going to obviously have xerostomia, loss of taste, mucositis, dysphagia, so difficulty swallowing, secondary infections of whatever, trismus, kind of difficulty moving their jaw, or TMJ issues in general, impaired nutrition. They just, like I said, there's pain to eating, and they just can't eat like healthy foods like they want to or used to perhaps. Hearing loss, it can actually affect if the radiation is in that area, they could have hearing loss. And then of course, feeling tired, which will affect many things. So that's acute. And then chronic, they may have permanent xerostomia or diminished salivary gland function. They may have permanent alterations in their taste, or it might just last for a while and take a while to recover. Telangiectasia, spider veins, so it can affect their blood vessels, and they can have kind of this spider vein, like lots of little tiny veins. Friable mucosa, so very fragile, thin mucosa. Continued fungal infections, osteoradionecrosis or soft tissue necrosis. And I have some more information in the notes there. Rampant caries, muscle fibrosis, TMJ disorders, trismus. So you can see there's a lot of overlap, altered tooth or jaw development if it's in children. So these can all happen acutely, likely will happen acutely, but all this stuff could hang around chronically as well. So they could, a year, 2 years post, they may still have these issues that you need to kind of help them through or remind them. So I wrote a little bit more about the trismus there in the notes that you can read on your own, and then also the oral radionecrosis. Let me see if there was something that I specifically wanted to. So osteoradionecrosis is different. We'll talk about the bisphosphonates here a little bit too. The bisphosphonates specifically are about the bone not being able to turn itself over. And so it's trying to build up bone, because you think about it for patients with osteoporosis, right? We want to build up their bone. So the bone's not like turning over, the cells aren't turning over. So that can become a problem if they've specifically had IV. So this is a different kind of cause as opposed to the osteoradionecrosis, which looks very similar, but is more about like blood loss supply and like death of the bone from the radiation. So they're kind of like look similar and might present similar, but they're sort of for different reasons. So make sure you kind of read a little bit about those so that you kind of have those in your head. Those for sure will show up on national board questions, osteoradionecrosis, and then the ONJ, that's slipping my mind for some reason to say it out loud, but the one that's caused from bisphosphonates. So primary treatment, so someone may have to undergo radical mandibular resection for an oral cancer, very disfiguring. This is a story, I can't remember his story. He's clearly a young guy when he was diagnosed. I want to say he was in his teens, and he used chewing tobacco, and which, I mean, people can go decades using chewing tobacco. This is just one of those examples of, you just never know what's going to be the environmental trigger that pulls some kind of a genetic, susceptibility. And so that's what you could kind of maybe assume, that that's what caused his oral cancer. But so he had to have, and maybe he just put it off, for years and years and years. I read his story. Maybe I have a link. No, that's just a picture. But you can look this up and find out the details. But anyways, you can see he had a major resection of his mandible, and it's very disfiguring. I mean, my goodness, it would be horrific. Even if you survived, you're just permanently disfigured. So there's a lot of psychological things that will go along with this kind of surgery. You have something like cancer of your spleen or something, and they remove your spleen, and if you live or what, you can go on without anyone knowing the difference. But oral cancer, it can, you can't hide that. So if there's surgery and it's a small lesion, it might not show up. It might just be something that they changed inside the mouth. You might see it as a hygienist, but the outward world might not see it. They could be completely excisable without complications, meaning they can take it out 100% without any problems. Not sensitive to radiation therapy would mean they need to surgically remove it. No involvement of lymph nodes, salivary glands, or bones, and if there's no involvement with the lymph nodes, they choose to remove it surgically. Recurrence of the tumor after radiation could be, they go in for surgery. That's another reason. So those are all primary treatments for surgery because of those bullet points. Here's another one. I had a patient that almost looked exactly like this. It was an older man, over 65, who had resection of his mandible. They found the cancer in our office. I think the doctor found it and referred him, and he went through major treatment and was in and out of our office while he was in treatment still. We saw him. And they actually put a rib in his jaw. They put a piece of his rib to build up his jaw, but he looked very similar to this gentleman. And the tissue just looks red. I mean, like, you can see, like, there's a lot of those varicosities, those little like spider veins. And so this just really reminded me of him. And a lot of times, of course, they're missing teeth. You take away a part of the mandible, you're going to take away the teeth, right? So they're going to have different prosthesis. But there are complications for physical complications: infections, airway obstruction, fistulas, necrosis, impairment of swallowing, impairment of hearing, depending on where the surgery is. It can affect their vision, smell, speech. I mean, just endless options that can really physically change a person's quality of life. You can see compromised nutrition, depending on how it affects their eating ability, swallowing, drooling. This one patient that we had at Dr. Liday's office when I worked for her, who had this, he just carried a cloth and constantly had to wipe this area all the time. He was just kind of drooling all the time. He just had to. And it was just part of what he had to do, like, all day long, every day. TMJ, facial deformity, and then psychosocial. You can obviously imagine the deformity, the disability, depression, anger, stigmatization of looking different, would be very hard psychologically. So they carry quite an emotional burden. They can. So it's important for us to treat them like every other patient. Obviously, that goes without saying, and being empathetic and helping them through this as best as we can, helping them find solutions to help them be more comfortable or function better. So some of the management by a dental hygienist: assess for oral irrigation and comfort using a water pick perhaps, and showing them how to use it in a different way. Maybe, they may have to lean a different way, do it over the sink, do it in the shower. Like, think of different ways that they could utilize tools to help cleanse their mouth. Empathetic listening and stress reduction. finding out what their routine is and then thinking of ways that they could implement things, you know, that would not stress them, but reduce their stress and help them maintain oral health. Oral hygiene, frequent gentle cleansing, hydration, an irrigating syringe, saline rinse, cotton-tipped applicators, or these little sponges for debridement, sponge swabs, and gauze. So there's lots of options out there. Oral cancer prosthetics after surgery. So we have these obturators. This can be used also for someone who has like a cleft palate. They've had any kind of surgery, then this basically fills the void, right? So if their palate is all open because they've resected some part of their palate for the cancer treatment, or we'll talk about this also, like I said, with cleft palates, then that just goes up and it fills it in so that they don't have this open tract from their sinuses into their oral cavity, right? So it kind of plugs the hole. So the shape of the oral cavity, they could have dryness, mouth dryness, thinned tissue or fibrous tissue, maxillary difficulties after surgery, a nasal voice quality that's going to change the sound tone of their voice, nasal or sinus secretions, facial disfigurement, difficulty swallowing, speaking, eating, and then needing a surgical obturator of some kind and having to maintain it, keep it clean. And then mandibular difficulties after surgery may need additional surgical procedures for function. So they may need something like, you know, multiple surgeries. The first surgery to take out the cancer, another surgery to build up function, doing something like putting in a part of your rib or something like that, whatever they would do for the surgery. So, so here's the bisphosphonates and the osteoradionecrosis. So this maybe sort of puts them together so you can see they're similar. They both are exposing just, you know, people oftentimes when the first time you see it, you may go, is that a tooth? Is that a tooth poking out? Like, what is that? And then you realize, oh no, that's bone. That is part of their jaw, just exposed. There's no gingiva covering it. It's just exposed. And it may look very uninflamed, or it could look a little inflamed around the borders. It's just depends. It can be, it can manifest differently. But the bisphosphonates, cancer patients are given bisphosphonates because of their levels of calcium and also some other reasons with bone pain and some other things. But like my aunt was given it to try and like pull out calcium from her blood. And so they're given bisphosphonates for different reasons. But if they're given a bisphosphonate, it alters the ability of the osteoclast to resorb. So that's, you know, we have the osteoblast, osteoclast, blast build it up, clasts take it away. It sort of pauses the taking of the bone away, which makes sense if you think about why they'd want to give it to somebody with osteoporosis, right? They want to build up the bone, but that can become a problem in some of these other situations. So it suppresses bone turnover and it increases bone density. Osteoradionecrosis is exposed bone. It won't heal as the result of the radiation. So usually that's like cutting off blood supply or killing like blood vessels, and it's like destroying the bone that way. Bisphosphonate related osteonecrosis of the jaw, that's the ONJ is just what they call it, osteonecrosis of the jaw, that's bisphosphonate related. Mostly you're going to see that with IV, like if somebody has been given bisphosphonates through an IV. Typically you won't see that as much if they're taking it orally. It's usually just IV. Prevention, complete all recommended dental work prior to treatment. This is one of the biggest reasons, amongst, of course, sepsis and other reasons why it's important to do all the dental work. But this is a big one. You don't want to do any implants or extractions if somebody has to have a bisphosphonate treatment. Meticulous oral hygiene to prevent things from happening down the road, because the half-life of bisphosphonate is 10 years. Remember drug half-lives? You take a Tylenol and the half-life of a Tylenol is like 3 hours. Like in 3 hours, 50% of the drug is of a Tylenol is out of your system. But if you take a bisphosphonate, in 10 years, half of the drug is out of your system. So that's why it causes such an issue, is because bisphosphonates live in your bone, like they're there for practically ever. So that's why it's an issue. So they have to be very proactive down the line, they have to always stay very proactive with their oral health care. Assessment of cancer patients' current oral status. Oh my gosh, you guys. Time goes way too fast. 7 more slides. So assessment of cancer patients' current oral status. We want to know their current oral status, health and dental history reviewed, frequency of care, dental experience, experiences that were painful, interviewing the patient with a cancer diagnosis to understand their perception of the disease. Like, you kind of want to know, where are they at with their cancer diagnosis? Like, they're the experts here. They're the ones that are getting all this information, and they may be in denial. They may want to poo-poo it, but it's so, you know, if they've marked it on their medical history, then you just want to very politely and understanding and you know, without kind of throwing them into a tizzy, you just want to have an understanding of what's going on, their health beliefs. So understanding, like, do they see this connection between their oral health and their systemic health? Because it's really vital that gently get that message across to them. Coping strategies, they're going to be very stressed out. Likely, nobody gets a cancer diagnosis and then feels unstressed. Usually they feel very stressed. So, but, you know, do they have a support system? Are there people that is there a husband or a wife that came with them that you can give them this information? Like, if you talk to them about oral mucosa and xerostomia, and if you happen to get put on a bisphosphonate, like, if you have this sort of talking points, can you get it written down and then give it to a husband or give it to a wife or give it to a child? Because a lot of times they feel very overwhelmed and they're not going to remember it. They're just not. So, you know, give that information in written form to somebody, either the patient if they came alone, or a caregiver, or, you know, a support system. And then dietary habits, giving them some nutritional counseling. So general dental hygiene care before treatment, to kind of summarize it: dental surgeries completed at least a week prior to chemo or immunosuppression. Dental surgeries completed at least 2 to 3 weeks. 2 to 3 weeks prior to radiation therapy. So they should get this stuff done weeks before treatment starts. Psychosocial issues, collaborate and give patients some sense of control, giving them options, you know, obviously being sensitive to the fact that they're overwhelmed with a lot of information. Education is important for the long term, so before, during, and after treatment. And then OHI and self-care, optimal to start treatment, but optimal before starting treatment, before tissue is compromised. So get them, hopefully we can get them in good habits before they start treatment. And then tobacco and alcohol cessation counseling. Oh, I skipped them. And then nutritional counseling and fluoride therapy. That was all that stuff. And then during treatment, all dental treatment finished before entering into cancer therapy. That's very important. It's possible patient could come in for cancer treatment, and if so, oncologists may prescribe a pre-med due to increased risk of infection. So that's why it's good to touch base with the oncologist. Do they need a pre-med? Support the patient, listen to the patient. If they're in treatment, they're probably feeling very tired, you know, and maybe grumpy or sad or stressed or afraid or just down in the dumps. Or they may be like a fighter, like, kick this butt. You know, you have those fight cancer bumper stickers, like F cancer. And so some people might take that approach and just want to be really proactive, and whatever I need to do, tell me I can do it. So you just never know what your patient's outlook is going to be like. So you have to just be open to that. Your patient's the expert. They have a lot of information about their disease and treatment. So you could probably learn some things about their specific situation, undoubtedly. And they might have an oncologist who's very proactive in oral stuff. So it's always good to see if you can learn something new from what they're going through. Mucositis, stomatitis, salivary dysfunction, infection. We've talked about all of these things. These are the highlighted. These things you should know front and back, that these are the things your patient is at risk for. The management of oral complications, just knowing that they're at risk. You don't necessarily need to know the prescription. If they get an infection, what would the prescription be? You don't have to know that for sure. It likely would be some kind of a systemic, you know, antifungal medication, but just knowing that these are the things they're at risk for, and how do we minimize that risk. And then during treatment, dietary concerns for those in cancer. So just again, some of the things we've already talked about. This is just reviewing it, making sure you understand these concepts of certain types of, food is going to be easier on them than others, keeping their mouth moisturized, never letting them kind of dry out because that can start them down the wrong path with harder to control mucositis. So nutritional counseling. And then after treatment, after chemo, likely a lot of things will resolve, but the things that don't resolve, to stay on top of with your patient and talk to them about, continuing frequent care visits and good oral hygiene and moisturizing the tissues and keeping the teeth cleansed and maybe using some extra fluoride, all these things that are just going to become very second nature to you, but seeing what their particular situation is. They may experience chronic candidal or hepatic lesions afterwards. Necessary dental treatment only after consultation with oncologists to assess immune status, pre-med, and platelet support. So if they've just come off of treatment, definitely, if they show up and they just came off of treatment, you should have touched base with the oncologist. They may be totally good to go. I guess I probably didn't tell you guys this because I probably wouldn't have brought it up. It was probably last year's class, but I always think I had a patient who was 97, 99. She was close to 100, and she had lymphoma. She had a some kind of a cancer with her lymph nodes. And she went through a full cancer treatment, full. It took her a year, and it almost didn't seem like it phased her. She was like, I was a little tired. I mean, and she had like chemotherapy. I mean, it's just, you just never know how people are going to respond. And then other people, it can just wipe them out and they can have all sorts of problems. So you just never know, but you definitely would want to connect with the oncologist just to be sure. After bone marrow transplant, the same thing, necessary dental treatment after consultation with the oncologist. And these are just sort of reiterating the things we talked about. Elective services after full hematologic function is back. They have to be up and running in good shape. Somebody who has had bone marrow transplant can't come in until they are really at a stable point, and they need to be cleared by their oncologist. And that can be up to a year after completion. So sometimes this is another interprofessional opportunity for hygienists who want to work in the hospital or outpatient. Some hygienists have gone and worked with oncologists and worked with cancer patients. So this is another, I didn't add any slides to this that highlight any specific ones that I found, but maybe I'll do that and upload them into Moodle, because it's another huge opportunity for hygienists to work with another healthcare practice. So after radiation, it's the same thing, monitoring salivary function and their risk for caries with these things that we give to everyone who is in that risk group. So you can read through that. This is the clinic manual. Last year, like I said, I will check to make sure that see if it was updated. This was last year's. So if someone's in chemotherapy, this is what our clinic says: possible antibiotic, we have to consult the physician, control spontaneous bleeding, topical fluoride, and xerostomia management, radiation, brush with a very soft toothbrush, chlorhexidine rinse, topical anesthetics prior to eating for pain if that's a problem for the patient, xerostomia management, daily fluoride, and management of fungal infection. So that's what we have in them as reminders in the clinic manual. So that is it for today. And there are 5 minutes to spare. So here's the handout that you guys can just bring next week. So you can grab one of these. And then don't forget to grab your one from last week that got checked off. So if we're done with this, this is the hand-in file from, these are people handed them in early last week. So this is if you have to hand it in for today. For what? The one that we got today. Oh, did you do it already? Yeah. Oh, sure. Yeah, you can just put it in that file. You can just put it in there. Yeah. Thank you. Yeah.
I know I'm spacing it. For xerostomia, there's palatal